everybody. Welcome back to the Little Brain Campaign podcast. I am your host, Dr. Lauren LaRose. I'm a board-certified child and adolescent psychiatrist and adult psychiatrist with a private practice in Metairie, Louisiana. And I have with me here Kelly Komisaruk. She is going to talk to us all about eating in kids, picky eating, something called ARFID, which I think a lot of people are starting to hear about. And we're just going to dig in on that. So thanks for being here, Kelly.
Sure. Thank you for inviting me.
Okay, so tell us a little bit about you and how did you get into this space?
Sure. So I'm actually a speech pathologist in Florida, and usually in the speech world, you hear all about late talkers and maybe helping autistic children, things like that. But there is a whole subset of us that does work with behavioral feeding, picky eating, everything like that. And as I was doing that, my caseload at the hospital I was at started to be more and more teenage based, which wasn't an oral motor difficulty or swallowing difficulty. It was really this fear and anxiety around eating. And that was about 10-ish years ago. And of course, I didn't have that much training in it. I had training in basics of feeding, but the anxiety piece was harder. At that hospital, I was lucky to get put on a multidisciplinary team with an occupational therapist who was awesome at regulation and learning all about sensory and everything like that. And then we also had a doctor of psychology on there who specialized in feeding. And she was like an ARFID expert. So for years and years, we all co-treated. And that's how I really got into this realm. I loved it. And so when I did my private practice, which I'm in now in a brick and mortar in Orlando, I really focused that practice on ARFID, which is what you mentioned, which we can talk about, and just like extremely selective eaters based on anxiety.
Okay.
Anxiety. Yeah.
Okay, great. And this is very relevant to my practice because this is something that I see all day long every day in my kids.
Yeah, in my world, it's really common, but in the general population, I think it does sound a little bit more, not new, but just, wow, what is this? Or what could it be?
Yeah. Okay. So tell us, how do we know when something is picky eating and when is it something more than that?
That's a great question. I get it all the time. Probably you do it as well. So,
yes.
All kids at around 2, give or take, they all become more selective. They all become what we might call, picky eaters. But that should resolve as they get more exposed to foods, and they're still going to have likes and dislikes. But there are that subset of kids who even past 3 are still very afraid of anything new, are very scared of even something like choking or getting sick, or kind of the mental health piece, something being expired or that making them sick. So once we get past that age 3 or so, and we start seeing that fear and anxiety with trying new foods, that's when we know that it might be something more. Some rules of thumb are, less than 20 foods, or maybe being extremely specific with, wow, my kid will do chicken nuggets, but it's got to be Wendy's.
Yeah.
Okay, so being very specific with brand or color or type, or even kind of just one whole food group. So my kid can do everything soft, but something crunchy will really overwhelm them and they can't handle anything crunchy. So when it gets to that level is when we know there's something more and that we need to intervene with professional help.
Okay. Got it. Okay. So what if you have a kid who starts out as a pretty good eater, eats a good variety of foods, and then they start to refuse foods?
So that's actually probably common in well over half the kids I see. When I take the parental intake, almost all of them, with a few don't, but almost all of them say, when my kid was 1 and we were introducing food, they were doing everything. And then, around that 2 or 3, we lost it. So that's a crucial time. So if you're noticing that the food is becoming, I almost call it a funnel, they used to do all these foods and now it's getting smaller and smaller. They're losing foods that they loved. Maybe they're pocketing foods in their mouth. Maybe they're starting to spit out foods they didn't used to do. Maybe they are becoming more brand specific, color specific. They're having certain rules around their foods. It's got to be this way. Yeah, I'll do a banana, but you have to cut it. I won't bite it. That's when we really want to kind of push gently those exposures in terms of, okay, you did used to do this. I know you don't want this now, but instead of just removing it from your plate, I'm still going to put it on there. Today, you don't have to eat it, but I'm not going to just remove that food from their diet. That's what happens a lot. Maybe someone will gag on a food, not choking, but just a gag. And parents, obviously get really worried and scared.
Yeah.
And so instead of working through that gag and teaching them that was a little uncomfortable, but I can handle it, we just remove that food because we don't want to see our kids uncomfortable. And that's then where all the food loss comes in.
Yeah, yeah. Okay, so, like, part of it is the kid developing these preferences for whatever reason,
Mhm.
and then part of it is us as adults, like, kind of, I guess, feeding into that,
Yeah,
right?
I mean, we do, and, we like to call it kind of accommodations,
Yeah.
which is kind of a can have a negative
Yep.
connotation. But really, we do. We all, no matter, I don't care who you
Yep.
talk to, everybody accommodates their kids
Yep.
in one way or another.
Yep.
But with feeding, it's kind of that extra element of, well, it's very emotional. It's highly emotional topic, and my kid's doing it all day, every day. So if you do start doing even small accommodations, it just escalates into like accommodating for everything. And by the time they're 15 and maybe see me, they've had accommodations for 10 or 12 years, and we have to undo a lot of those things.
Yeah, yeah. And I know a big part of it is the fear that, like, if I don't give my kid the food that they're going to eat, then they're not going to eat,
That's a
right?
huge fear. It's a huge fear. And we don't want kids to miss a meal or skip a meal. And I understand that,
Yeah.
and I don't, in my practice and just what I teach in my courses, I never promote like a starve it out method or
Yeah.
don't give your child what they need. But if you have a child that is relatively healthy, right, they're not significantly underweight, they're not meeting with GI teams to talk about alternative forms of nutrition or hydration. If they're just a typical kid and extremely selective, if they do eat less for a meal or two, or they do miss dinner that you would have liked them to have more, that really is okay.
Yeah.
We have to, as parents, be okay with that too. Not starving our kids, but being okay with them. Okay, so they missed. It's
Yeah.
not. It's not really going to make or break it. It's going to have such a positive impact in the future if you continue to do it correctly.
Right. Right. Okay. Okay. Okay, what about like kids who are afraid of trying new foods?
So kids that are afraid of trying new foods are pretty much over 50% of the bulk of my my
Okay.
population, right? So
Mhm.
whether they are neurotypical or whether they have something like autism or are neurodiverse, and just sometimes just sensations in their mouth are very overwhelming.
Mhm.
Sometimes just a new food is just too scary. It's out of routine for them. So what we do is we work on just going up like a small mountain or a small ladder, however it works best, right? And
Mhm.
starting so small and getting some level of comfortability at that low level. If that means that the food's on the plate and they're at dinner, that's great. If that means that they're able to pick it up and kind of put it in their mouth, but they're not ready to chew and swallow it, that's okay. They're allowed to take it out. Every one of those baby steps are really important. Because what I find is parents are often like, okay, pretend it's a strawberry. My kid does not eat strawberries, right? So at the top of the rung will be, I would love my kid to eat strawberries. At the bottom is they're not eating it. So when you're in therapy or when you're working on it, you're doing maybe 20 steps in between. And
Mhm.
that's what you're learning how to do in therapy, is really doing all those steps in between that get them to eating instead of just eating or not. And that's
Okay.
kind of what we're missing.
Okay, so it's like a gradual exposure
And when
to
I
that
say
food.
small, I mean small. Sometimes it's even just poking the fork into the strawberry and having residue on it and then getting the fork in our mouth. And
Okay.
sometimes initial bites are the size of a grain of rice,
Yeah.
just kind of so you can mentally tell yourself, especially if you have a teenager, so you can tell yourself, hey, I did chew and swallow that food. Like, and I'm okay. Like now
Mhm.
reflecting back on it, I'm okay. Instead of having it be a big bite and you gag and you have to take it out. And it's just a bunch of little wins are way more important than a giant fail.
Yeah.
So as many times as you can get those wins, it's really big.
Yeah. Yeah. It's actually sounds a lot like how we treat OCD. You know,
Yes,
that it's like this
it is.
exposure response prevention,
Yes,
like learning that like I can expose myself to this anxiety provoking thing and I'm still okay and I'm
it
still
is.
alive. Yeah.
hmm And with feeding too, a lot of times since the food is removed, we don't give our kids the opportunity to even figure out if they're okay with it or not.
Mhm.
They don't even have the opportunity because we're not exposing them to it. And no judgment on the parents. I
Yeah.
understand. But it's just, they don't even have the opportunity to be like, well, was I okay eating that or not? I don't
Yeah.
even know at this point.
Yeah. Yep. Yep. Okay. Um, okay, so if you have a kid who has picky eating and you've tried like traditional feeding therapy and that's not working out so well, is there something else that you would recommend for
hmm
those families?
Yeah, sometimes traditional feeding therapy doesn't always work, unfortunately, for a variety of reasons. We can switch to a parent training program where the child doesn't even need to come to therapy. This is not a parent training program where I just train you how to do what I do. That would be like a traditional feeding therapy, right? We
Mhm.
work on it, we teach the parents, things like that. This is a model where you don't need to bring your kids to therapy.
Mhm.
It's rooted in something called space, which you might you might be familiar with.
No, what's that?
Trading space. So it was not created by me. It was created by a doctor at Yale, Ellie Lebowitz, and it stands for Supportive Parenting for Anxious Childhood Emotions.
Okay.
So it's how to reduce all those accommodations. Mine is based around feeding. It can be for general anxiety, social anxiety, everything. Mine is based around food. It's how to teach parents to reduce the accommodations while also supporting their children.
Okay.
So instead of just saying, hey, I'm not giving you this food anymore, it teaches you the roadmap and how to reduce those accommodations. So you don't need to be stuck in that cycle of restriction all the time.
Okay. Okay. And it's a long process, I'm assuming,
It's a
right?
long process, yes. So like, for example, this space program that I was talking about, it's a short in terms of parents learning how to do it, maybe a month or two, but the effects of it, you're working on it for weeks and weeks and months and months.
Yeah, because it's hard it's hard for kids to unlearn behavior. It's really hard for us as adults to unlearn behavior,
It is. And we look at our kids that are anxious around food. And then when you look at the parents, they're often anxious around it too. Like you can see it. They're going to gag on it. They're going to lose their safe food. They're going to not eat dinner. Like all that anxiety is a big part of feeding therapy and even the space program. It's not just the kids' anxiety.
Yeah. Okay. Do you see, so like on that note, do you tend to see families where like, the kid has some kind of like picky eating or ARFID or whatever, and then there's also some kind of history in the parents of anxiety or eating issues?
And I hear that all the time. Oh, I was like this as a kid. And, most parents that are maybe in their 30s or 40s, it was treated a lot differently back then. So they don't want to repeat the same things that they had to go through, which is understandable. But then it's kind of like the pendulum has just swung so far the other way that we don't have anything in the middle right now that's really helping kids who are really suffering.
Yeah. Yeah. Okay. Okay, so I see, this is something I see a lot, where you have a kid who has very picky eating, but despite that, somehow they're growing perfectly normally. And so like the pediatrician's just like, don't worry about it,
Like, which is very frustrating for parents, whether they're just looking for guidance or whether they're looking for like a referral for insurance. Either way, it's really frustrating. And I do have a lot of kids that would even be classified maybe as overweight, because you can imagine if they're eating pasta and not getting protein and they're just trying to fill up all the time, it's an abundance. Or kids that are just drinking milk all the time to supplement. Sometimes they're at a weight that they are considered to be overweight. So what I do tell to them is I have a note that I share with my families that they're supposed to take to their doctor, and it's like a checklist, and it's just called Note from My Doctor, and it's a checklist. It says, yes, my child is on the on the growth chart, he's fine, 50%, whatever. But, and then I have them go through all the things, such as I have to pack an extra suitcase when I travel. I have a 12-year-old and I still have a diaper bag full of food. I can't go to a restaurant that my child won't eat at. And the sibling is like, why do we always have to go to the same place? So all those things that affect you are very, very important in terms of social development and family dynamics, that it's not just if your child's on the growth chart or not. So I try to give my parents that checklist so they can at least share with their doctor without having to come up with it on the spot. They can go through and say, hey, this is happening.
Yeah. And I mean, you can have normal growth as a kid and be normal weight, normal BMI, normal height, but have a nutritional deficiency because
100%.
because of your picky eating.
Yes, you definitely can.
Yep. Okay. Okay. So what about kids who gag when they eat new foods?
That's a hard one, right? It's very hard. So we want to make sure we're differentiating between gag, which is even kids that are just babies that are learning foods. That's considered, sometimes they're going to gag on foods, right? And choking. Choking is a serious medical issue. And sometimes I think parents confuse the two.
Yeah.
When you have a picky eater, if they put a new food in their mouth and they've never had it before and they really are uncomfortable with it, there's a really high likelihood they're going to gag, right? So, but it's not the level of like choking. Oh my gosh, I need to help my kid at this point, right? We want to think of it as like when you're learning to walk, your kid is going to fall, right? So as a parent, you're probably going to be like, okay, you're going to make sure they're okay, but not in a very, oh my gosh, what's happening, right? You're just going to pick them back up. Okay, brush off their knees, whatever, and let's walk again. With feeding, you want to do that same thing. You have a gag. Okay, you're going to make sure they're okay, which they almost always are. And then instead of just like with walking, you wouldn't pick them up and carry them. You put them right back down and have them walk again. With feeding, you would keep that same food, maybe decrease the bite size a little bit and have them do it again and show themselves like, hey, I'm totally fine. This was just new for me.
Yeah.
And I think that's where a lot of the foods that get lost really get lost in that cycle of, well, they're scared now. They gagged on it. Dad's scared, mom's scared. And it's a big, messy thing to kind of unravel and unwind.
Yeah. Yep. Yep. Well, and I don't know if this is something that you talk to parents about at all, but, or kids, that like when you gag, that's, like food going into your esophagus, right? And you're gagging versus when you're choking, it's going into your
windpipe.
Windpipe,
Yeah,
right?
yeah.
So like gagging is not dangerous.
It's
It's
not dangerous.
uncomfortable.
It is. Nobody wants to do that.
Right.
And yeah. But the parent's reaction to it is sometimes like it is a choke. And then that makes the kid scared. And then there's all that more kind of reasoning for, well, not having this food anymore. Well,
yeah.
They'll even intermix the words. I choked on it last time. Well, no, it was a little gag. It was new. And the more we avoid, the more that avoidance just grows. And so by the time they're 10, maybe there's like a giant avoidance monster in the room.
Yeah.
Right? It's just grown so big. Every time you avoid, it just gets bigger.
Yep. Yep. Okay. Let's talk about ARFID. Can you explain what ARFID is for people who don't know about it?
So ARFID, it stands for Avoidant Restrictive Food Intake Disorder. And it's relatively newer in, 10 to 12-ish years. And I would say even the past couple years, and it's not like it hasn't been around for longer than that. It just hasn't been recognized. So I would say even the past 2 to 3 years, it's gotten a lot more media attention and a lot more parents trying to help others become more aware of it. So really that's when you see feeding disorder, eating disorder without some other reasoning behind it, except for that anxiety. So my kid can chew and swallow just fine, but they're still having a really hard time with eating because they're so fearful. It's that anxiety component. It's that, oh my gosh, I can't do that. Like so fearful, almost like if you had a fear of heights or a fear of flying.
Right.
Same concept, not because of something else underlying.
Okay. So it's basically like, this like whole picky eating idea is like on a spectrum and ARFID is at like the more extreme end of that spectrum, right?
Yeah, it's often at the more extreme in that a kid with just picky eating, you can usually coax, bribe their way into tasting almost anything. It might not stay as part of their diet, but you can like, even if it's hard and it's a battle, you can like get them to try it. Somebody with true ARFID, you are not going to get that person to even try a food.
Yeah.
It's like that. It's that hardcore.
Yeah. Yeah. Okay. And are you seeing this in just kids or are you seeing it in kids and adults?
No, I see it in adults too. Often. Yeah. And then I think one area that comes out a lot, at least for me, is like the kids who have kind of they're young adults, like going off to college. So like my whole life changing. I don't have mom and dad there anymore. Not getting grandma's cooking. I'm going to have dorm food. I can't eat on my own because that's a big component of ARFID too, is like the social piece. You have a lot of kids who just will not eat in social situations. Yeah. So if you're at college, sometimes that's really hard. You don't have a lot of the privacy that you had before.
Right.
So that's where I see a lot of parents sort of help their kids get help. Well, young adults get help is that kind of 18, 19-year-old. They're also usually more motivated, right? These people are like, I've struggled with this my whole life. I'm now 18. I want to be free of this restriction.
Yeah.
So I have a lot of people seek help at that age.
Okay. Can you tell us about like the social piece? Like why do they tend to avoid eating in social settings?
Yeah. Sometimes there's a lot of different kind of reasoning behind that. Sometimes it's just so overwhelming with the sounds and the people talking. And some people are really highly sensitive to like other people chewing or seeing another person maybe eating a food or like the smell of a food that's really unpleasant. And it just makes them shut down. So a coping strategy that they've done is instead of not eating, they're just like, well, I'll just eat on my own. I won't deal with that sound. I won't deal with that smell. I won't deal with that look. I won't deal with any of it. So it's just easier to eat kind of on your own than to have to struggle through all those things or to not eat. That's the worst case scenario, right? If you're going to not eat or eat alone, probably what's happened is they're like, well, I'll just eat alone rather than not eat. And that's what the parents have supported.
Yeah. Yeah. Okay.
Right?
Okay. So that's probably a piece that like people don't think about as these kids grow is that, meals should be a social experience,
Good.
and so the kids, not only are they risking like having nutritional deficiency, they're also this is also inhibiting that social bonding time.
It is. It's a really big part of it. And that's when you talk about ARFID, that's another diagnosing criteria is that they're impacted socially.
Mm-hmm.
It doesn't have to be, right? But it's not like you have to have like 3 of 5 things. It's just really one flag for a diagnosis. But one of them is a social aspect. So
Mm-hmm.
even socially, like kids can't go to summer camp. I have kids that are homeschooled because they can't
Yeah.
handle eating at school, can't go to birthday parties. So all that kind of stuff. So the social part is really big, and it's
Yeah.
a huge quality of life thing, even if
Yeah.
it's not a health thing. That's a big component when you're looking at a 10-year-old who's going to have to do this for another 80 years, right?
Yeah.
Yeah,
Yep. Yep. So it sounds like it really gets to a point where it just like is controlling their entire life.
it is.
Yeah. Okay. Um, so I always like a lot of these episodes bring back to something that my child deals with. So my son has PANS. Are you familiar
Mm-hmm.
with PANS?
Mm-hmm.
And like a component of that is like this restrictive
It
eating
is.
and ARFID. Is that something that you've been seeing in your practice?
Mm-hmm. Yep, yep. That's actually, I wouldn't say common, but definitely has come up throughout the years,
Mm-hmm.
100%. And there's, I think, a lot more research. You might know a lot more about this. There's a lot of research being done in that area
Yeah.
with PANS and ARFID and all that restrictive rules and things like that. So I don't know if you have any more insight into all the research that's been done.
I'm trying to keep up with it.
It's a lot. It is a lot.
It's a lot.
It's a lot.
And it's like you can go down this rabbit hole with it. Do you treat those kids any different? Like if it's coming from like a PANS root
No, not
cause?
because really the outcome needs to be the same, right? So we do want to always know the root cause, but the roadmap for treatment is still helping that child learn to be okay with being a little bit uncomfortable and
Yeah.
then keep pushing that boundary a little bit more and more. So I think of it as like they're in kind of like a bubble, whatever the root cause is, they're in a bubble. And instead of jumping out and then crashing, we just want to like stick a pinky out and oh, I'm okay, I'm fine. And then we stick a little bit more out. So we do want to know the root cause for sure, but it just helps us to be a little bit more thoughtful about foods we pick, reasonings behind it. And I don't know, if your listeners are getting feeding therapy right now, as a provider, I always have the kids, even if they're little, have some type of stake in what the next foods are that are going to be tried.
Mm-hmm.
So there's a lot of providers who will just pick, but I always make sure that the kid is involved and invested. That's really, really important.
Yeah, because then you're like helping to maintain that at least some level of autonomy for them.
Yes, of course. You want to pick something way out in left field, right? You want to pick something that at least sparks their interest a little bit. And you might need to help them get there, right? You might need to come up with a variety of things or reasons, but you do want them to have some type of kind of want to go to that next level, some type of intrinsic motivation.
Yeah. Yep. Yep. So do you think like looking at, picky eating as a spectrum, in your mind, like how you conceptualize it, do you think that it comes from a place of like needing to exert control at certain developmental stages, or is that not really
I
what it
think
is?
I think a lot of our kids do. I think a lot of it is control, and that is one thing that, and as we know, potty training, that's like a couple
Yeah.
of things our kids can really, really control food going in and food coming out, right?
Uh-huh.
And they know, and even kids as little as like 3, they can see the anxiety on their parents. They know when they are kind of controlling the situation with the food. I think a lot of times it does come from a place of, if I have a kiddo that isn't chewing well and they can't really verbally express, well, this is uncomfortable for me, I don't know what to do with it. So they just start ruling out foods, and it looks like picky eating, but it's really that root cause would be oral motor. Or maybe you have an autistic kiddo who's very sensitive with certain textures, but they're not able to really tell you like, this is so uncomfortable for me. So they just start refusing. So there's a lot of root causes that end up looking like picky eating, but really it's just a root cause that we're maybe not aware of at the time.
Okay. So it's like the outward manifestation. Hey, buddy.
Sorry, I'm almost done.
No, that's fine. This is part of the deal. We're moms.
Right?
So like the outward symptoms or manifestation is the same, but like the original cause might be different, but you end up treating it the same way.
Yeah. I mean, you will end up treating it. You won't treat the anxiety differently, but if it's oral motor difficulty, you would of course treat the oral motor component. Or if it was a difficulty with a sensation in your mouth, you would talk through the sensation. So you do need to know the root cause, but still reducing that anxiety is always what you're getting at.
Yep.
Whether the anxiety comes from a texture or the anxiety comes from a skill base.
Okay. Yeah. So if you could get in front of a family that has like a brand new baby and tell them, like, what advice would you give them to hopefully avoid ending up with a picky eater?
Yeah. So the three biggest things I would probably tell them is don't remove a food if your child gags. Right? Okay. And then I would tell them it's totally normal for kids to kind of go up and down, right? It's normal for them to like one food and one day and not the next, but it's up to you to not then remove that from the rotation of foods. Right? So that's really, really important. And then what I would say, and it's a brand new baby, so you're not going to be thinking this, so much, but I would say once you start realizing that you are accommodating too much, you need to reduce those accommodations as soon as you can and teach your kids that, yes, I'm here to support you. I'm going to help you, but you don't need all this level of support. You don't need me to have you eat in a different room. You don't need me to remove this food from your plate. It's uncomfortable for you, but you can totally handle uncomfortable things from an early age.
So it's like prevention is the best way. Early intervention is the next best.
And
then you're there for the other families.
For all the rest. Yes, exactly.
Okay. Well, tell people how they can find you.
Okay. So you can find me on my website. It's food, the number 4 thought therapy. So www.food4therapy.shop, SHOP. So you can find me there. You can email me at kelly@food4thoughttherapy. And I can, have some links for you that you can just send when you post this.
All right. Amazing. Well, thanks so much for being here, Kelly. I appreciate it.
Of course. Thank you.
All right. Thanks everybody for listening. Thank you for tuning in to this episode of the Little Brain Campaign podcast. If you enjoyed our conversation, give us a follow on your favorite podcast platform so you never miss an episode. Please take a moment to leave a review while you're still thinking about it. It really helps grow the podcast, and I love hearing from our listeners. See you next time.